I want to talk a little bit about sacral pelvic fixation. My disclosures, hopefully not too relevant today. So whenever I talk about sacral pelvic fixation, I usually start with this case presentation. It's something we published several years ago that just demonstrates some of the complexities of what we're really talking about. So it's a 55-year-old female. She has had a spondylolisthesis at L5S1, underwent this operation from L4 to S1, and then comes in looking like this. So she's been like this for a few years. So she had this surgery. You can see, or maybe you can't, but there's an inner body at each of those levels. So they did, T-lift for a PLIF, and did an L4 to S1, partially reduced that listhesis, and thought all was well. It obviously isn't. She is somebody, when you see people that are kyphotic at their lumbosacral junction, you can't miss them walking down the hall. They look terrible. They can't stand up very well. They're really far forward. And if you look where, a plumb line would be, if you drew one up from the back of her sacrum, it never touches their body again. So that's a complex problem for a variety of reasons. So when we did that workup, it revealed a S1, S2 fracture. So she fractured, she kind of plowed her S1 screws, fractured below, which is not all that uncommon. And then she healed that fracture in kyphosis. So she changed, pelvic incidence is supposed to be the same, right? We're not supposed to be able to change it. Well, she changed her pelvic incidence, is now abnormally high because she's fractured through. And if you remember, pelvic incidence is measured off that sacral end plate. If you change the angle of your S1 end plate, you change your pelvic incidence. So when you're trying to figure out what are we going to do with this lady, there's a few issues involved. Bone quality obviously is a concern. She's fractured through, a lot of force down there. She's failed the surgery already. Getting her sagittal alignment back is going to be really tricky. And what are we going to do for caudal fixation? Where she's already down to S1 and that's failed. So now what do we do with that? So when you talk about reconstruction, the sacrum is where we end a lot of our constructs, but it's not a great fixation point. So the sacrum is this large, mostly cancellous bone, and it doesn't have a pedicle like the other vertebral bodies do. When you think about getting screw purchase, you're filling the pedicle. That's how you're getting fixation on pedicle screws. That's why they're strong, because they engage that cortex as it goes down. You can't engage the sacral cortex. There's just a big gap of bone. And so that's why you really need to think about what you're doing. If you look at those slides there, it starts at the sacral promontory, and as you go down, it gets pretty cancellous pretty fast. And there's a lot of force down here. So if you think about, as you're standing up, all the forces you're putting on, every time you bend over, somebody that's sagittally imbalanced leaning over adds a significant amount of force right at the bottom of their spine there, which becomes a big deal. The bigger the patient, the more obesity they have a big belly hanging out in front. That's putting all kinds of stress and strain down to those caudal implants. Malalignments, high pelvic incidence, all adds to the forces you see down there. So when we talk about sacral fixation, that's where it starts, right? If we're fixating down to the bottom, we're talking about what do we fixate for the sacrum. So your options are S1, S2 screws, Alar screws, intrasacral rod, Sacral Iliac screws, or some combination thereof, and we'll talk about some of those. Obviously, in this, whatever the modern era of spine surgery, a few of those techniques have taken off. A few of those have really gone to the wayside, but we'll talk about some from historical perspective as well. So pedicle fixation in the sacrum, S1 is your best fixation point. That's why we stop at S1. But S1 screws all depend on how you place them. A unicortical S1 screw is not very strong. It engages just that relatively thin posterior cortex and sits in that sea of cancellous bone. That's not a very good screw. A bicortical screw is better, significantly better, but a tricortical screw, which is the screw you see, the top screw in that picture where you're talking about a screw that goes to the sacral promontory. Biomechanically, you can see those two graphs there. That's bicortical versus tricortical fixation. The reason it's called tricortical is because you're getting sort of the anterior cortical bone and then that end plate bone where it's nice and thick near the top there. So you get a significant increase in at least the insertional torque measured in these screws by 99%, going from bicortical just to tricortical. It's not always easy to get it right at that spot, but that should be your goal. And when you try and place these screws, you're trying to get it just through the front. So I usually measure a screw. If I'm putting my screw in, I measure to what I think the front is, and I go whatever the next size up. I'm trying to go 5 millimeters up. I'm not trying to go more than 5 millimeters sticking through the front. You don't want to end up with a screw that's abutting one of the vessels or something else, because the radiologist will be calling you. Then you'll be wondering, what do I do about this now? And that's not the situation you want to be in. So an S1 screw, and I'm sure you all put in S1 screws. I don't want to belabor it too much, but these can be placed with fluoro, with navigation. I place them freehand. entry points that I take that facet that, I think of the S1 pedicle very much like a lumbar pedicle. It's just the facet complex is the facet complex, and the sacral ala is like your transverse process. So right at that inferior edge of that superior facet of S1 on the lateral border there is where that screw usually goes in. I pay a lot of attention to my rod run. So when we're putting in screws, I want my L4, my L5, and my S1 screws going in. If you put an L4 screw in and then an L5 screw out laterally and you pull your S1 screw back immediately, it makes for a painful little rod run. Things that trend in the same direction, easy. Things that zigzag, really hard. So modifying that a little bit, paying attention to what your rods are going to look like at the end, will save you a lot of trouble at the end. So that's the estimated entry point for that. You make a breach, you use your probe, whether you use a straight probe, an angled probe, it's all up to you. If you like to use fluoro, usually that's using a lateral fluoroscopy, trying to aim for that sacral promontory. If you use navigation, that's you're using the 3D imaging. You probe that anterior cortex. I tend to tap these. That's a image where you see with a ball tip probe in there all the way going to that sacral promontory. That's the trajectory you want on these screws. If you're going to tap the probe, or if you're going to tap it, if you use K-wires, if you're doing minimally invasive when you're tapping, make sure you don't go through that front of that anterior cortex first. You need to leave that anterior cortex, or you can't put a K-wire in there safely. If you don't use it, you don't use it. You then, in somebody with really strong bone, you do want to pop through the front there to make sure you get through. Most screws are a little bit aggressive enough at the tip these days that if you don't go through there in somebody with regular bone, it will go through. But beware, if you put that screw in and it starts to turn without advancing, you've just stripped that hole and you got to redo it, and it's a problem. So I've seen that happen. It can really bugger up your fixation pretty quickly. And again, don't try and be more than 5 millimeters through the anterior cortex, but you do want to be through the front. I use a Lenke style gear shift probe to place these, and instead of where you use a Lenke probe, you usually put that curve medially to go against the pedicle. I place it going cephalad, so it actually bounces off that S1 end plate. I'm trying to buffer against there and feel that all the way to the front, and that tends to work really well. I used to put screws in with fluoro, then we put screws in with nav, and then I started putting them in freehand. I swear my freehand screws are more at the sacral promontory than any of my other techniques, just because you can feel it, and it doesn't take long to get the hang of that. So, and it certainly speeds up. Not using any fluoro or nav to put screws in it certainly cuts time off your case. So S1 screws fail. How do they fail? Oftentimes they fail by plow. So as somebody leans forward, puts a cantilever force on there, it plows the screw through the bone. You get S1 screw pullout. You can get S1 screw breakage. So I put 7.5 millimeter screws most of the time at S1, unless I'm going bigger for some reason. I try not to put anything smaller because there's a lot of strain on there. They can break. If the bone just halos out around them, you end up with a real mess, and it becomes hard to salvage. So an example of that, here's a 55-year-old obese female that came to me. She had like I think a L3 to S1 fusion done, came in with a lot of pain. She's sitting in a wheelchair, takes care of her grandchild who runs around and gets her all of her stuff. But she looks like this, and you can see she's got a big iliac crest graft on one side and some really haloed out screws. I salvaged that. I was able to get a sacral screw on the one side. The other side, I couldn't get anything in there, but I put doubled up iliac screws and actually put a little trans-iliac bar to connect them to augment some of my fixation, and fortunately we got her to heal using that. That was many years ago now. So S1 screws fail. That's why we have all these other adjunctive techniques that you're probably here to learn and play with in the lab today. All the other techniques, all the S2AI, iliac screws, all the things you hear about, they're adjunctive techniques. They're meant to back up the S1. They're meant to reduce the strain on your S1 screws. That's your caudal fixation. That's your caudal motion segment. You see people that skip S1 to put in a minimally invasive screw or do something like that. I'm a believer that you are missing the forest for the trees on that one. Those are adjunctive techniques trying to back up an S1 screw. They're not meant to be the standalone caudal fixation. And I'll show you an example of that. So this is, I think, he's a psychology professor at our institution who ended up having a surgery by one of our other surgeons. He had a T10 to S1 for primarily degenerative disease. You see, I only have supine x-rays because I got called in after this had gone on for a while, and he was never able to stand up and walk. So he had surgery, had an infection, got washed out, redo, wash out, some sort of a flap, still was non-ambulatory, had all kinds of pain, and we get called because he's not doing very well, and he was demanding a second opinion, so I had to come in and see him. And you can't really see it here, but he's got a cage that doesn't look like it's very well positioned. And I read through his notes. He's got notes that say he's neurovascularly intact, and I go examine. He's got bilateral foot drops. I'm like, does anybody know he's got foot drops? So get a CT scan, and it looks like this. You can see the cage is all the way back in the canal. He's got a long construct ending at S1, not great. He had a pliff done, so he had aggressive takedown of both sides, and cages put in, so he had very little fixation at the bottom. Holding wasn't very strong, and you can see those screws are all haled out at S1. So he underwent a revision, again, not by me. They just extended down to S1. They took out those S1 screws and put in iliac screws. So they did what I just said. Iliac screws are designed to back up S1 screws. So he's already failed at the bottom. They just pulled out those screws and took that cage out and then put in iliac screws. So it doesn't take long. You can see his x-ray here is sitting, so he's still not standing up. He's now got a sitting x-rays now a couple months from that operation, and he's haled out his iliac screws, and then finally comes in to see me for yet another revision. And we ended up doing this. He had infections and problems, so I used a mesh cage actually in the front. I did an anterior to get some interbody support, got some sacral screws in via a little bit of a different pathway, and then some iliac screws, and finally got him to heal. But it was like a 6-month saga for this guy that probably could have been avoided just with some iliac screws up front. And there, you can see him healed there. So indications for adjunctive fixation in my mind are long segment constructs, and for me that's anything L2 to S1 or going higher. People with osteoporosis, it really, we try not to operate on osteoporosis. We try and do a lot of bone health type things before we operate on people now, but I pay attention to that, and I'm more likely to put in iliac screws the softer the bone is. Spondylolisthesis, particularly anything high grade, really consider adjunctive fixation. People with sagittal coronal imbalance, correcting it is one thing. It helps you correct it because you can use a cantilever force. You can, fix your rods at the bottom and really push, and it helps rotate things around. If you're going to have any residual imbalance, it's certainly going to put a lot of strain there. So if you can get it sort of better but not perfect, even more indications to have a good solid fixation at the bottom. So adjunctive techniques, S2 is an option, not very common these days. Only reduces the strain on your S1 screws by about 15 to 20%, so not significantly. A little higher risk. It's a short little pedicle. There's not a lot to say about it. I don't know anybody that routinely uses that as their option. Sacral alar screws are something that actually have some reasonable resistance, 20 to 30% reducing strain on that. They were in vogue a few years ago, like an S2 alar screw, not an S2 alar iliac screw. This is a little different angle. It's a screw that angles up and out into the ala. There's some old plates, Colorado plates, and other things that you may see just when you have to do redos on some things that were done a long time ago that had a combination where the S1 screw in through one hole, alar screws went out into the other. It does add some resistance in a lower demand construct. It's a reasonable thing to know. Jackson intrasacral rods, these are historical perspective only. I don't know anybody that does that, but this is a rod that actually the base of the rod is driven down into the sacrum and then extended up. So it provided some cantilever force. So as a patient bends forward, or cantilever resistance, it was buttressed against the bone to help take some strain off of those S1 screws. Not an easy thing to do. If, some of these old techniques, you look at people and say, wow, you must have been pretty hard to get the rods in, to get a straight rod and bend it appropriately and get it to go there. Definitely not easy. But the problem with that screw is, if you can see up in the upper right-hand corner there, the top circles where that rod would be, you'd place it there. It's kind of a cancellous structure in the sacrum there, and it tends to just plow. As they bend, it tends to migrate posteriorly, and you end up with something that's a failed intrasacral rod there. It just ends up plowing there, and people end up with an imbalance. Then that gets a little bit tricky to treat. So iliac fixation, it's an example of a Galveston intra-iliac rods. Again, another complex rod bending thing. Usually in neuromuscular kids, that was a common technique. Again, I'm glad I don't do those because they look like they'd be painful. Iliac screws are not painful. Trans-iliac rods and the sacroiliac screws, and obviously the S2AI is one that's getting a lot of prominence and taken off in the last several years. So iliac screws, why do we use them? Well, they reduce strain on your S1 screws by 70%, so significant reduction in pain. They increase your fusion rate at L5S1, so you decrease the motion, increase your fusion rate, and decrease your failure mechanism. And again, failures at the bottom of your construct are significant, right? They end up with significant imbalances, and it's really hard to salvage, so you don't want to see that. Complication rate traditionally was noted to be pretty high. I would argue that that's sort of the old-fashioned iliac screws, and we'll talk about that as we talk a little bit more about S2AI. Screw back out 4% breakage, 5% not so high, but gluteal pain 18%. That's a significant number. If they have gluteal pain and you take that out, it usually does get better. There are studies that show that, but that's pretty high. But again, that's sometimes a prominence issue, and it's a technique-dependent problem. Fixating across the sacroiliac joint does impact ambulation. People walk differently. They don't run very well, so they need to know that. And it's the prominence of those screws that you really have to pay attention to, and there are several different techniques to how to put them in to try and reduce that problem. People talk about removing iliac screws for pain. I've got hundreds of people walking around with iliac screws. I've never removed a single one for pain. So I think there's certainly a technique issue on how you put those in prominence. This is a graph showing flexion loads to failure on S1 screws. So the left is S1 screws alone, the far right is S1 plus iliac screws. You can see that that's by far the best adjunctive technique in this study. So why are they good? Well, this is why they work. So if you look at the instantaneous axis of rotation with the little circle there, your S1 screws do get in front of that. So as you flex forward, it gets a little bit in front. Alar screws are the ones you see there going out into just the sacral iliac, a little bit in front as well. The iliac screws get so much further in the front of that axis of rotation, and they're buttressed against the sciatic notch where you have really thick cortical bone. So as somebody bends forward, that the force is going to push that screw against that really hard bone, and you're going to have significant, that's where all the force is going to be. Those S1 screws aren't going to see much of it, and that's why they work so well. It's all about getting in front of that flexion axis. So traditional iliac screw insertion, entry point is near the posterior superior iliac spine. You can see a picture there. I tend to scoot it just a notch more caudally than that picture shows. The illustration you see here where they cut the back of that, sort of the PSIS back to that little drop off you see there, I don't do that either. I'm in the middle of those two. I try and leave a little bit of bone, and you'll see that. We're going to do a demo for the lab, so you'll see what I mean by that, and I try and bury that screw within that bone. Some people just drill into the bone, some people cut a notch. Again, various techniques. I'm going to show you mine. I'm a notch cutter on that. Anyway, you get into the bone, you pass the probe. You can use fluoroscopy. There's different ways to use fluoroscopy. You can use AP fluoroscopy. You can use lateral fluoroscopy, trying to just aim it above the sciatic notch. Or you can use what's called the teardrop view, where you're looking right down the barrel. Teardrop view gives a really nice look at it, but it's in the way. You know, if you don't like fluoro, you're not going to like the teardrop view because I don't like it because it's in the way, and I got to work around it, and so I tend not to use that. But we'll show that on the demo. And the goal is to get right above that sciatic notch. So you're getting a long screw in front of that, or just above that sciatic notch contained within the bone, that you then connect to your construct. So you pass it through, you can see those there. Those are getting, you can see near that sciatic notch, not quite right on it, but generally if you're in that zone, they're pretty good. They don't tend to fail. Oftentimes you need an offset connector. That's the most common way to do that. If you really try and angle it in the medial portion of the ilium and angle across, maybe you can run your rod in there. I find it's hardest if you're kind of in no man's land. You want to be far enough away that the connector actually can fit and have a little bit of space. If you get them really close together, you're trying to use small connectors, it actually makes it a little harder. Kind of like in a cervical where you, if you have lateral mass screws and they don't run and you want to use a connector, it has to either be really out of line or right in line, because that sort of no man's land gets a little tricky because nothing fits. You can still harvest iliac crest bone graft. You can go in and take one where you see the illustration there. I traditionally, when I take my notch out, I save that bone for iliac graft. Then I take a pituitary, maybe a curette, and go up in a cephalad trajectory away from where my screw is going to go and harvest a reasonable amount of some iliac bone. And if I'm doing T-lifts, I use that to fill all my T-lift cages. It really gets a nice fusion rate, and you've done iliac grafting without any of the morbidity of it, because you're not taking down any of the lateral cortex, you're not stripping gluteus medius, you're not doing the things that cause pain with iliac grafting as well. I've got some videos that we're going to skip here, I think, so because we're going to show it in the lab. And that was the guy that we did that on. So S2 Alar Iliac screw, newer technique, everybody's really excited about it. Came out of Hopkins. They're big on it there and do a really nice job of it and do quite a bit of it. Eventually, or originally started in these neuromuscular children where implant prominence was a problem, and trying to drop these screws down. It's essentially a screw that goes through the sacrum at the S2 level, through the sacroiliac joint, into the pelvis, and then ends there. It's a little more technically challenging screw to place than a traditional iliac, at least in my mind it is, but it's still not a overly difficult screw, and it's a technique certainly worth knowing. You can see here's a paper here showing a fluoroscopic shot of it, showing what some screws look like. You can see they run right with the rod. There's no offset connector needed for these screws, which is quite helpful. You can see the fluoroscopy there with the probe going across that sacroiliac joint. This is how I place them. So it's essentially you find the S1 and the S2 foramen. You go between them just a little bit off center, so I kind of get that lateral edge of that of the foramen because you want it to run with your S1 screw. So again, you got to pay attention and cheat it a little bit if you need to, just for rod run purposes. It's usually about 10 degrees caudal and about 30 degrees lateral. I usually find if you still have your sacral spinous processes, the probe almost rests on them. It's kind of in the way for where you're going. And you're going to go across 4 millimeters or so. You're going to get into that SI joint, feel it pop through, get hard again, and then get back into bone. It looks like that, again, trying to pass right over the top of that sciatic notch. These need to be big screws so they don't break, so you usually want 8.5 millimeter screws, and you can get long screws up to 100. I tend to think they're more in the 80 to 90 is what I seem to get, but people get 100 screws pretty routinely. So fluoroscopy, you can use the AP view to make sure you're staying out of the sciatic notch there. We'll use that teardrop view routinely to do these as well. So there's been all kinds of papers on S2 AI screws, and I'm a believer that if you read the literature, you always got to ask what's the bias of the author, and everybody's got a bias. We all do. I've got a bias, and I didn't write any of these papers. The authors certainly do, and when we show some of these studies, you definitely can see that come through. Here's one looking at biomechanical evaluation of S2 Alar Iliac screws versus, so they took iliac screws, 2 lengths of S2 AI screws, and then a quad cortical screw. So that means you get your sacral cortex. Cortex 1 is the front of the SI joint. Cortex 2 is the second side of the SI joint, or that's cortex 3, and then actually popping back out through the pelvis to get another cortical fixation, which you think would be super strong, and they were all about the same. So a traditional iliac screw fared as well as even the quad cortical S2 AI screws. So most people believe that they're equivalent from a biomechanical standpoint. So you're not getting better fixation with one or the other, better reduction of strain on your S1 screws. It's just which screws can work better for this patient. Here's a study looking at the S2AI versus iliac. They found better outcomes in the S2 AI group. Less implant loosening, 18.6% versus 0% in the S2 AI. Less breakage, less pain, and fewer revisions. I want you to look at that. Fewer revisions, 11.6% versus 0. And then in their paper, they show this. Broken S1 screws, broken S2 AI screws. They had 0% revision rate. So I don't know what this person's doing, but I feel bad for them. And then there's this, you talk about S2 AI screws. My concern with it always is, do they break at the SI joint? If they break across a mobile SI joint, you put a screw across a mobile joint and it breaks, what do you do with it? Because you cannot get that tip out. If it's broken and it's in that joint, if it's painful, you're in trouble because you cannot get there without really damaging and just destroying the whole system to get in there. And everybody says, well, they don't break. Well, this is a special screw that's been designed for this. If you can look, it's only threaded at the tip. It's got an extra thick, the outer diameter, if you look at the screw here. So the outer diameter here matches the outer diameter here. That's not a normal screw, right? You usually have an inner diameter and outer diameter. So it's extra thick, and you heard earlier that it's exponentially strong as you do that. And then it's extra thick right here where a screw usually has a head. The only reason people redesign things isn't just because. It's because something's failed, right? If you're redesigning a screw, there's all these special nuances, so it's extra strong places. That's because it's failed at those places, I guarantee it. Heads have popped off, screws are broken. It happens, otherwise this screw wouldn't exist. Here's a European study group showing exactly the opposite. So S2AI versus iliac wing screws, 35% failure in the S2AI, 12 in the iliac wing. Again, wherever your bias is, you can find the literature to support it. The key is to know both techniques. This is out of Hopkins, and I'm friends with these guys, so I think they're good surgeons and do well. But if you look at their study, S2AI revision rate 8.8%, iliac screws 48% revision rate, infection rate 44% infection rate. If you have a 44% infection rate on anything you're doing, stop. just stop. Don't do it again. So I don't know what they were doing on those, but that's the concern here. It's not how good these are, it's how bad those were. Because I don't have a 44% infection rate. Last year, we get tracked our statistics. I had a 0.8% infection rate last year, and I did a lot of iliac screws. So I don't know what happens where, but again, the literature, right, this shows, oh, S2AI is better. But no, that's not really how you should read this paper in my mind. Then they looked at the prominence of those screws, and they measured the distance from the skin to the screw and how much that would hurt from prominence. And then they drew these pictures of where they put their iliac screws. And then I realized what the problem is. They're putting their iliac screws right under the skin. They're leaving it on top of the bone. Well, of course that's going to be prominent. Of course that's going to be a problem. If you put it there, that's not what I would consider a modern era iliac screw. That's original technique from many, many years ago. So it's all how you do it. And again, learn both. You should know both. I use both. But don't wed yourself to anyone because you can find the literature to back up anything. So pros and cons of that. Pros, strong fixation. There's no need for an offset connector, absolutely. Runs in line, great for MIS for that. Low profile, I mean, I think so. It sits beneath the pelvis, but if you sit your iliac screw into the pelvis as well, I don't think it's any lower profile. Cons, we don't know the long-term durability, although we're getting longer data, and it's looking better. The longer it goes, the more happy I am with it. A little bit harder to place, and I don't think it's as low profile compared to it, depending on, again, how you put your iliac screws in. So here's how I tend to use that. Here's something that's came to me, failed at the bottom, lots of previous surgery. I put in screws like this. I'll oftentimes combo an iliac screw with an S2AI if I'm trying to get extra fixation at the caudal thing. They tend to marry up nicely. You can put one and then the other in. You just got to put your iliac screw in a little bit higher. So I put the S2AI in first, then just come a little bit higher with the iliac screw. Here's a 72-year-old, had this a scoliosis operation done, persistent pain, spinal cord stimulator. Everybody says, well, there's nothing really you can do. Comes to see me for like a third opinion, and you just look at it, and it's not really hard to figure out. He's haloing everything. He's got a long construct, ending at S1, no inner body, no iliacs. Failure rate's pretty high on that, and he's got an S1 screw that you can see is right up against his S1 nerve, even on a non-contrasted CT scan. So he ends up with a revision that looks something like this. I put an inner body in from the front to try and salvage this, and then dual screws on the side there. Another one here, this is a lady with a large sacral tumor. It was a schwannoma that had just not very much bone, so we used a combination technique there as well. Trans-iliac bar type things is something we don't do very often. This is an old-fashioned technique. Steve Andre, my mentor, used to do these sometimes, and he called them crowd pleasers because a lot of people come in to see it because it was pretty crazy. But that trans-iliac bar was put in essentially through and through, and I'll show you a picture of that. This is one of our sacral osteotomies, like the patient I showed you to start with, where you can see a trans-iliac bar placed. Essentially, if you take out the sacrum and you disconnect the pelvis, you've got an unstable situation. You need to reconnect that ring, whether you put a rod across there to connect two of those screws or a bar that goes through, they're all a part of that. You can see this one here. This is one where the bar actually went through that cage. It's not sitting on anything, so I don't know if it does any good, but it actually ended up healing, so I guess it worked. Here's one here. You can see it was this nerve root sparing sacrectomy, and you can see this rod here, the little connector over here, was put through, and it's going to get pulled actually through, and then a connector put on the other side to hold that together. And we tend to just run the little rod across now because it seems a lot easier than that. So back to our case to finish up here. This is a S1, S2 fracture again, where we had that elevated pelvic incidence. We treated that with like a pedicle subtraction osteotomy, which we call sacral subtraction osteotomy at the S2 segment. So we actually changed the pelvic incidence and then had to reconstruct that with multiple rods and we reconnected the sacral or the pelvic ring with that trans-iliac bar as well. And you can see a significant change in alignment without a significant change in lumbar lordosis, all just fixing at that sacral end. And she's now 7 years from that operation and continues to do well. A few more of those. Another patient, you can see this is not a uncommon scenario. Somebody gets a long segment construct with S1 that fails and people just ignore it, put them in a brace or do something else. That's not a good idea. If you see it failing, take them back, put in the iliac screws before it becomes this because it gets really hard to fix. So an osteotomy there again. You can see the pre and the post, a significant change in posture, less lumbar lordosis than she started with actually in most of these cases, just by fixing the pelvic incidence. Another one here, instrumentation was in and then removed. Gets that there. And this was a mistake. It worked, but it was really difficult as a mild meningocele patient. So the sacrum wasn't normal down there to begin with, and it wasn't a fracture of the sacrum. It was a mismatch but it was congenitally abnormal. And I tried to do it, and it's better, you can see, but it's not a lot better. And you can see how crowded all those implants get. I got limited by how much I could squeeze them because everything touched, and I couldn't close it anymore. So if there's not a big gap between where you are to start with, you can't close very much. So that was a lesson I learned on that one. You can see that there. So in conclusion, appreciation the unique biomechanical role of the sacrum and pelvis is really important. You got to know how to put good sacral screws in, and all the different types of pelvic screws if you're going to do anything other than real short segment constructs. Paying attention to bone quality, paying attention to biomechanics, know why you're doing it and what the techniques are and what your goals are really important. And hopefully you get to practice a lot of it in the lab here. It's a great time to fiddle around with it. And if you're really good at placing these screws, I always tell people, if you're really good at placing any screw in a cadaver lab setting, if it's pedicle screw, iliac screw, whatever, try and screw them up. See what it feels like when you fail. See what it feels like when you get into find the sciatic notch. See if you can pop yourself into there. It's really hard to do. See if you can get in the sacroiliac joint. See what it feels like. If you're just learning how to do it, try and get the feel of how it goes through that bone. Use the fluoro. Use everything you need to. If you're really good at it, try and goof it up. Thank you.